care team, we want to be able to say that we are going deeper and deeper, just like the nurses, just like the physicians, just like, and you can add anybody onto that team that you like. And we said, we need advanced chaplaincy education. We need to be able to look at the specific needs of chaplains in healthcare today, not when I did my CPE at MD Anderson in the dark ages, but today's needs have changed. Even in the last 5 years that I've been at St. Luke's, it's changed incredibly. And so we start today with a program that, as Dr. Graham said, we hope to have many, many more offerings for you in the very near future. And I begin with one of our vice presidents from St. Luke's. Dr. McIlwain has not been there that long, but he has become a good and fast friend in a very short time. He brings some perspectives that you'll want to hear, and he'll be watching you very closely because he's not only a medical doctor, but he is a psychiatrist as well. So be careful. Dr. McIlwain.
Thank you. Thank you. It's a great privilege to be with you here today. Gary told me as we were eating lunch that I'm what's called a token administrator here today. But I thought it would be very important that I really make sure you know from whence I come. You should know first and foremost that I am a dyed-in-the-wool Scots-Irish Presbyterian.
Oh, right.
All my life. Fourth Presbyterian Church, Greenville, South Carolina, and so on. So now that you know that, let me tell you a little bit else about me and how I ended up here at St. Luke's. I have a good Presbyterian education at a college called Davidson College near Charlotte, North Carolina, where you do your mandatory 12 hours of religion and they get you full up, at least for a couple of years. I went to medical school in Charleston, South Carolina. Family's originally from South Carolina. Trained at West Virginia University back in the day when I was a whitewater canoeist, and West Virginia had the best whitewater on the East Coast. My father had grown up in Atlanta and was best friends with the guy who wrote Deliverance, Jim Dickey. So that's what got me interested. Had an obligation with Uncle, and spent 4 years in Germany after that. Another 3 years in the Army at Fort Leavenworth for the short course. As you always qualify, there's a place where people stay long-term at Leavenworth too. And then back to North Carolina, to Fayetteville, North Carolina, in the 82nd Airborne Division. I was the chief medical officer there. Family decided that we'd had too much moving, and because North and South Carolina were our home states, remained there until I came to Houston. In the interim, became interested in quality, patient safety, had a number of responsibilities working both for the health system and group and solo private practice for a number of years. But had the great fortune of spending a year in Boston at the Institute for Healthcare Improvement. Got to share an office with Don Berwick and became Berwickized. I don't know if you know, but Don is knighted. He's been tapped. In fact, all the paraphernalia is in one of the showcases at IHI is Sir Don. And it's an experience when you get to meet and be around Don, who is as genuine a person as I've ever met, that you sort of become anointed with the Don version of the Holy Grail to go out and transform healthcare. So that's my mission in life, to diligently transform healthcare. So I want to begin today creating a metaphor, and I'm going to need some assistance. Here, Steve, help me out. I want to share with you what I think, unfortunately, has come to represent our view of the patient. Today, this, if you don't recognize it, is a surgical drape. We're going to kind of unfold it for you here. It's rather large. Contains all sorts of parts. It's got some sticky pieces. So I'm going to grab that end, and we'll just sort of do this. And unfold it and unravel it. And we'll
That's where you do the cutting right there.
Yeah, I mean, in fact, if you'll hold this corner and we'll just sort of hold it up, you know, this sort of represents what a patient has become, what you see in this hole, if you will, just that small part. And unfortunately, I think has come to represent how many of us view the patients that we treat. Just this little piece. It just happens to overlie that part for the moment in which I have an interest. And it's rare that we connect with everything else that's under or behind this drape. And I would suggest to you that many of the challenges we face today are the consequence of only seeing a piece of the person who really underlies these drapes. So I want to begin with one of these pieces of homework. It's the article that looks like this because I think this should guide and direct everything that occurs in and around healthcare today. I'm sure you're familiar with the Institute of Medicine's report, Crossing the Quality Chasm. It was published 11 years ago now. And I think provides the focus for what I want to talk about in the next 15, 20 minutes with you. If you turn to the third page, on the top left in italics, here are the words: safe, effective, patient-centered, timely, efficient, and equitable. Those are now the aims of the Institute of Medicine. Safe, effective, patient-centered, equitable, timely. The one we're going to talk about today is mostly patient-centered, but I believe that they're intimately connected with the work that all of us do, and particularly with connecting with that substance that lies behind that hole from top to bottom, from head to toe. And that many of the problems that we face in our organizations today are the consequence of our focus only on what's in the window rather than on the rest of what lies behind that. 10 rules for redesign. I ask you to look at those for a moment. I'm not going to read them to you. But contemplate the implications as we move into the future, where limits become the rule, limits become the norm, and we have to abide by the constraints that are going to impact all of us. And ask whether or not the 6 aims and these 10 rules for redesign help shape and govern your practices in your organizations, the values that are espoused, or the behaviors that are exhibited by folks. Part of the reason I came to St. Luke's, part of the purposeful reason for choosing to be in a faith-based organization, is that I was convinced, having spent many years in a public not-for-profit, in the military, so seeing and observing hospitals throughout the U.S. and in fact throughout Western Europe as well, that the best chance to realize these rules for redesign, to realize the 6 aims, lay in an organization that at its core had the basis of what I had grown up as part of my faith and my heritage and my tradition, that I could realize most in St. Luke's. And so far, so good. I mean, I've met Gary. We've done some work together. We're making progress. But I want to begin with this as our framework, because I really want to share with you some thoughts that I have about why we're in trouble, what the issues are. And I want to begin by moving to the next article, this one in particular, and asking that you turn to Exhibit 3, the executive summary.
Are there more?
I can make sure you have one.
I don't know, I got something that says executive.
That's a different executive summary. I'll give you this one. It's got the picture on the front. Now, if you notice, the title is Local Variation, Overall Health System Performance. There are two clusters, top 10% of local areas and bottom 10% of local areas. Why don't you take a few minutes and read down the list.
Which page are you on?
It's Exhibit 3. It looks like this. See any familiar names there? How many of you knew this before arriving here today? How many of you would have said, the city, the home of the Texas Medical Center, that the overall ranking, according to a host of metrics that you can read and understand, would place Houston, Texas in the metropolitan area in the bottom 10% of health system performance? Is there anyone who would have believed that? Really?
I'm a nurse by first vocation and educated on the East Coast.
Where?
Philadelphia and Charlottesville. One of my professional shocks when I came to Houston was that we were practicing nursing here about 30 years behind where I had trained. And I was a campus pastor at this medical center here for 6 years, and some of the faculty who would come from places like Detroit or other would say it's still that way.
It's very sobering when you begin to look at these kinds of measures and metrics that get very close to home in a community that prides itself, quite frankly, in having some of the greatest capabilities medically of any place in the world. In fact, it's shocking. Almost to the point that when you begin to look at the demographics of the community and what's happened in Houston in the last 30 to 40 years, and the community diversity and the disparities that come with those, that such could exist in a city that's one of the wealthiest cities in the U.S., certainly.
Something that struck me as I looked over the list. Bottom 10%, pretty much all in the South geographically. The upper 10 or just draw a circle around it. It was West Coast, East Coast, and Upper Midwest.
Upper Midwest.
Very strong in Upper Midwest. And so I wonder what the geographical message is there. I don't know.
Well, there's a very powerful one. Historically, Mississippi, Louisiana, and Alabama have been challenged for years and years and years. You know, high rates of poverty, high proportions of African American citizens as a major driver.
But even places like Texas ranked 47th in mental health care availability. And
Yeah, you don't want me to get started on mental health.
well, as chaplains, sometimes we are the default care provider because there's, and you know, my documentations when I was here was, you know, services refused by so-and-so, so-and-so, therefore I will continue to see patient, you know, sort of offering a disclaimer since I'm not a licensed counselor.
I understand.
Yeah.
Mental health reform has wreaked havoc across the U.S. I can speak both professionally. I can also speak personally as an individual whose youngest brother has a severe, persistent, very profound psychiatric illness. I think it's useful when we have these kinds of conversations to understand the current state of affairs here. If you click a couple of rungs up the ladder and look at the U.S. and its relationship to the other industrialized democracies, you would find that despite spending almost $2 on average for every one spent on the average of the other industrialized democracies, the U.S. performance metrics in terms of quality, safety, access, and a whole host of other measures ranks it essentially at the bottom of the heap. So the challenge that underlies all of healthcare reform is an issue of the value proposition. We are technological marvels. And over the last 30 to 40 years, most of the advances that have given the U.S. the edge in terms of delivering health care have largely been technologically based, and unfortunately, I think are largely responsible for us beginning to see only pieces of people at a time and forgetting the global part. The fear I have, frankly, is that as dollars shrivel, that we're going to remain technologically focused. I've already seen it in my specialty. You know, in some sense, a society's measure is how it treats the least amongst us. And I can assure you that people with psychiatric illness are in that population who represent the least amongst us, and we're not doing a very good job. So the question is, sir?
I can tell I'm in Harris County psychiatric, and they keep wanting to cut our budgets like nobody's business. In fact, right now, if it wasn't for Medicare and Medicaid actually, you know, being more involved with us, we would probably be shut down.
I understand that. And I have no doubt that here in Harris County there are some politicians whose route to survival is to discontinue psychiatric service if they could.
We've got some pretty good support from some of the local politicians. In fact, we have two county units that are competent restoration, one that's a county unit for juvenile probation. And those contracts mean a lot for our hospital to be able to treat indigent people. So we can't write too much about the county. We can write a lot about the state.
Oh, absolutely.
Too much about the county.
Sir.
In San Antonio, we've got 2 downtown hospitals, and the city has built something they call Haven for Hope. It's a quote shelter for homeless people. And because of the location, they're within about a 2-block walk for either of our 2 hospitals. And
There's 3 downtown hospitals.
yeah, Metropolitan Methodist, I'm sorry. So these are folks that show up in our emergency room a lot. Mm-hmm. And one of the patterns is because they have no health insurance, because they're unfunded, they don't have a regular doctor, they don't do any kind of wellness thing, they use the emergency room as other people would use a family physician. You know, when the gurney rolls in and the guy on the gurney says, "Hello, Charlie, get me a ham sandwich," you're looking at a frequent flyer. And we spend a lot of our resources dealing with the fact that these people don't have any other resources. I don't know what that does to the metrics that are involved.
There are some of them.
No, put it back. I'll take care of this. Please.
Some of the metrics begin to address those if you read. And I really brought these as an opportunity just to give you some background as you begin to contemplate that.
If you'd put that a little higher, actually, then I can turn this down.
Okay?
All right.
How's that?
Let's try it.
Is that still working okay? Everyone can hear? I have a theory about that, and I'll be the first to admit that I'm a contrarian. I don't think there's anyone in the U.S. who's uninsured. I think the real problem is not that they're uninsured, it's that their benefit plan stinks. Because their benefit plan will provide emergency care for you anytime you walk into the emergency room in the most expensive, least efficient venue for you to get your care for chronic disease that exists. And then we're going to ensure that you don't have good follow-up care, so you'll continue to use the resource that's in your benefits package that's mandated because the federal government, as one of its unfunded mandates, has passed a law called EMTALA that says anyone who shows up at the door to the emergency room has to have a medical screening exam, and if they have emergency medical condition, must be stabilized. So that's your benefits package. So this notion that there are uninsured, in my simple way of thinking, is really not true. We've made a conscious decision as a society to just provide a very poor benefits package that ensures that they're going to continue to get their care in this least effective, high-cost arena, and ensures that they're going to continue to deteriorate over time until they have to be in the hospital for extended periods for high-end care. That's to me the paradox of opposition to healthcare reform, regardless of how you characterize it. And the structure. There's a guy that I learned a lot from. He's a fellow named Paul Batalden. Some of you may have heard of him. Paul Batalden used to be the chief medical officer for the Hospital Corporation of America before Rick Scott. You know, the guy that's now the governor of Florida who destroyed HCA. This is personal. HCA actually used to be a very reputable, high-performing organization. Then it merged with a group called Columbia. Sort of fell off the cliff. Paul Batalden was the chief medical officer amongst one of his many duties. He was the chief medical officer for Job Corps at one point in time. Now he leads an organization called the Dartmouth Institute at Dartmouth University. Paul is infamously quoted as saying, "Every system is perfectly designed to achieve the results it gets." It's one of those things that I have to think about constantly when we have these failures in healthcare, failures in our delivery platform that are enormously expensive, very inefficient, and often result in outcomes that are not particularly desirable for the patient. That in fact our system is designed to produce what we're seeing, and that the solution is redesign of the system. And that becomes ever more important as we confront the notion of increasing spending for healthcare with declining return on that investment and gross disparities in the delivery platform that affect many of you every day. So let me commend to you the next article in the sequence. It looks like this because this explains what the problem is. The title is called "The Tragedy of the Commons." It was written back in 1968 by a biologist named Garrett Hardin. And the model is that of the commons, such as the Boston Commons or the commons that exist in colonial Williamsburg, the common grazing property that existed in most communities in the 17th, 18th, and on into the 19th centuries, where every individual who was a member of the community had the right to graze his herd on the commons, a shared resource for the benefit of all to be used by individuals who had the capacity to make autonomous, independent decisions about the size of their herd and how many cattle they were going to graze on the commons. Now speculate for a moment what happens when 100 people each decide to add one cow to their herd and have that one additional cow graze on the commons. Or 2 cows, or 5 cows. At some point you reach a limit for the carrying capacity of the commons, and what happens to the grazing properties of the space?
The grass is gone.
The grass is gone, and everyone suffers. So I would suggest that this whole notion of the tragedy of the commons, as Garrett Hardin does, is part of the issue surrounding global warming, grazing land in the American West, water rights, shipping water from the Colorado River Basin over the mountains into California to satisfy people in the Central Valley. I would also suggest that the problem that confronts us in healthcare is not dissimilar, that we in fact are suffering from that tragedy of the commons, where independent doctors and independent patients are making independent decisions about the resources that they're going to consume, resources that are functionally held in common, are here for the betterment of our society. And that as we approach this limit, where the spending for healthcare is no longer sustainable, we're going to reach this crisis caused by the enormous freedom that we desire because we have no means to govern the commons, no means to say, doctor, there's a limit to what we can do. That your decision to keep a patient in the intensive care unit for 2 additional days is unwarranted based on the condition of the patient. Well, I refuse to move them out. But what happens to the person then in the emergency room whose deathly ill on a ventilator who needs that bed, and you have no means to reconcile that decision. That's a problem every day at St. Luke's, and I dare say at every one of your hospitals, where those conflicts between independent decisions affect the resources that we hold in common, that tragedy of the commons, and that the freedom that we've historically enjoyed creates an enormous challenge for us in terms of our governance. And one that's not going to be easily solved, by the way, because our cultural heritage is to endow physicians with enormous autonomy. In fact, from the time you start medical school through your residency, you're trained in what's functionally a craft-based model, not dissimilar from the way guilds were constructed in the Middle Ages, to construct a perfect solution for each patient one at a time, to avoid that cookbook medicine stuff. To do it your way because you know best for your patient. And you should be given the range of freedom to make those independent decisions as you think best treats the needs of your patient. It creates enormous problems for people in my position when I clearly recognize that this patient doesn't need the ICU patient, or maybe this patient would be better served from an end-of-life discussion rather than continuing to receive futile care. And knowing that physicians are loath to have that conversation with patients. And yet one of the most powerful drivers of mortality, or reduction of mortality, the way it's currently measured, is in fact a viable and vital palliative care service and hospice service. Because what happens based upon the rules is when someone now qualifies for comfort care, for hospice care, they don't count in the denominator that CMS collects against which you're measured. Because you're no longer pursuing curative treatment or active treatment. And doctors are enormously, you know the specialty least likely to make a referral for palliative care? Which, amongst physicians, which specialty?
Oncology.
Bingo. And in fact, it's very paradoxical, don't you think? Sorry.
I was an oncology chaplain for 4.5 years at Catholic Hospital in Illinois. And what I heard, this was 60s, no, 95, 96. What I heard from the physicians was, oh, if we stop treating, they'll lose hope.
Well, I've gotten that lecture.
And the nurse practitioner that I worked with on that oncology unit, she said, there's always hope. She said, sometimes the hope is for a gentle death, but there's always hope. And the fact that the physician's idea of what's keeping the patient going, what's important to the patient, is continuing treatment as the only source of hope, kind of colors everything else that happens.
You know, that's kind of why I started off with those 10 rules for redesign. Because ultimately I do intend to cycle back to this whole notion of what patient-centric care is. And how vital talking to the patient and the patient's family becomes. And how our focus on what's in the window that doesn't necessarily support that conversation. That the patient is more than just that body part, but rather is not only a physical, but a social and emotional and spiritual being, and all of those components are vital in the healing process. You guys believe that, I hope. You wouldn't be here. You wouldn't do what you do. I believe you believe that. It's part of the reason why I'm so connected with Gary, and why I think the work that Gary and the chaplains at St. Luke's do is so important. Because unless we can address all of those components and do so simultaneously, we miss the boat. And the consequence is we struggle with those HCAP scores, those willingness to recommend, overall rating of care, doctor communication, nurse communication, cleanliness, and quiet at night. Not that I look at these things periodically. Now let me just make sure you understand the rules. There's this thing called value-based purchasing. It fundamentally says that hospitals that participate in the Medicare-Medicaid program, Medicare in particular, are going to have in the current fiscal year 1% of their Medicare payments withheld. You have an opportunity to earn it back. In fact, if you do very well, you can earn back up to 103% of that amount. 70% of your capacity to earn that back will be based upon quality scores, core measures. All or none, acute myocardial infarction, congestive heart failure, pneumonia, and the Surgical Care Improvement Project. How you score. You can go check your scores. They're published on Hospital Compare. And then the other 30% is based upon your performance on your HCAHPS measures. Those are also published publicly, you know. hospitalcompare.hhs.gov, I think, is a website. So your public scorecard is out there for everyone and his brother to see. And 30% of that amount, that 1% this year, can be recovered based upon your performance there. There's a baseline measurement interval, there's a measurement interval, and you have to exceed certain thresholds, and the formula, as you might imagine, coming from the federal government is pretty complex. But it's very real and clearly getting hospitals' attentions, because you know what happens in year 2? It goes to 1.25%. In year 3, 1.5%. In year 4, 1.75. Guess what happens in year 5? 2%. 2% of your Medicare reimbursement is a pretty big number. At St. Luke's Episcopal Hospital in year 1, it's well over $1 million. Most hospitals, that's bottom line, by the way. That's what's down there at the very bottom. And most hospitals don't want to see that money go, particularly in an era when they recognize reimbursement is going to be flat and there are enormous assaults on there. So this notion of how you attend to everything else that's underneath that sheet besides what's in that little window becomes very important, and many hospitals have spent hundreds of thousands of dollars to improve those scores. So they engage organizations like we did at St. Luke called the Studer Group, and they begin to teach what the people at the Ritz-Carlton or Disney or some of these other service organizations know quite well. There's another reason. This is probably, from my perspective, even more important. Why CMS in particular became vitally concerned about patient satisfaction. If patients are happy with the service, guess what? Turns out they get better. They get better quicker. They get better at lower cost. One's perceptions of your care have an influence through all those funky connections and neurochemicals that roll around up there with your clinical outcomes. And thus it becomes vitally important that we attempt to address everything that's behind that sheet, not just part. People can be awfully distressed with the service they receive despite the fact that their physical needs were met and cared for. Believe me, one of the organizations at St. Luke's that reports to me is our patient services department. That's where you go to complain.
I think the chaplain should report to you.
I don't know if I can handle that. Sir.
To give justice to some medical practitioners, some school of medicine will offer some courses on spirituality, and we do see that in some of the younger doctors. But there are still also some tendency, even for the younger doctors, to continue to advance the idea that care is doing something for the patient, and that's medically. Recently we had the Converging Road Conference in San Antonio, and one of the speakers is from Temple, Texas. He's in charge of the residents there, and he said that, I still could not believe that one of my residents would say, hey, we're withdrawing care for the patient. You know, of course, the idea of care is then is that doing something for the patient. He would always say that, hey, you're not withdrawing care for the patient. We withdraw life support, but the care can still be given. Connected with what you were saying a while ago.
But that's
It's the question of the understanding here.
Absolutely.
You know,
And that
care is
terminology,
limited in the
withdrawing
medical
care.
That's
Correct.
correct. It's
Equals
limited.
turn off the vent.
That's correct. And
So-
he said, no, care, even if after the withdrawal of life support, care can still be given.
Oh, absolutely. In fact, I remember the first time I had to write and sign a prescription for a patient after I graduated from medical school as a resident. I mean, I can close my eyes and see that. I can tell you it was at one of those moments where you draw that deep breath and you say, oh, God, this is for real now. Because never before had that kind of decision rested solely on my shoulders. And I began to think about or contemplate the implications for the decisions that I made and the privilege that I'd been granted. Essentially chosen by society for unique rights and privileges in much the same way that you are by virtue of your education. You know things about people that few other people are entitled to know. You can touch people. I can touch people in unique ways that don't put me in jail. I'm given that privilege within the context of this relationship. I have knowledge of people. Now, that's an enormous privilege. It's also an enormous burden that I treat that very respectfully. And I understand that one of my roles, the roles entrusted to me by the state of South Carolina for allowing me to attend their state-sponsored medical school, the state of North Carolina for giving me a license to practice, was that I also had responsibility. And there's a unique responsibility that occurs for physicians as well as for ministers at transitions, at birth. And that obligation is quite powerful. It's equally powerful at the other end. And sadly, as I look at my colleagues, sometimes I think we're remiss in understanding that our obligation is equally great at the end of life as it is at the beginning. And that's to ease suffering, relieve fear, to provide support, because that's care in the same way that signing that prescription is care. That's equally important to that patient and is interestingly likely to help them live a better and in fact a longer life than all of the aggressive medical intervention that can be administered in the absence of that. I don't know if you're aware of it, but New England Journal within the last year or so published an article that essentially said excellent palliative care extends life rather than ends it early. And in fact, it's the aggressive medical interventions that we administer that shorten life, and furthermore, not only shorten it, but make people very miserable. Ma'am?
One of the things I don't think we get as a culture is preventive care. We have this medical center over here, which is a worldwide mecca of allopathic medicine, and we train this many physicians to treat this many patients. And over at this end, we have this many patients, and we train this many physicians to take care of them. I'm kind of quoting Granger Westberg. In other words,
It causes you to scratch your head, doesn't it?
Yeah.
Actually, an article just appeared, I think, in, I can't remember, there's a New England Journal, the Journal of American Medical Association, that looked at the amount of training that the typical cardiology fellow got in the prevention of heart disease rather than the intervention for heart disease, and found the training programs woefully lacking. Public health is not high on the priority list for our system. Remember, every system is perfectly designed to achieve the results it gets. So our system is not designed to promote health of the population.
It wants to make sick people so we can treat them.
It's a great situation for doctors and hospitals, isn't it? Sir?
I can't chapter and verse it, but NPR had a thing a year or so ago a physician in France who makes house calls and whose stated principle of care is that the most important thing you can ever do for the patient is listen to them.
Sure.
Because if you listen to them, they'll tell you what's wrong with them. Without tests, without machines, without whatever, they'll tell you what's wrong with them. And sometimes just by having a conversation, you can alleviate the distress that's causing the symptoms.
So I'm running out of time, so I'm going to circle to the end. There are articles that I read over the years that go into my top 10 list of things that everyone ought to read. Garrett Hardin's article is one of those. That's foundational knowledge. Another one is this article by someone for whom I have, and I will admit, unabashed positive regard, Dr. Don Berwick. He is an American treasure. This is
that in the
Health Affairs is the first page. The title of the article is What Patient-Centered Should Mean, Confessions of an Extremist. Because of those 6 IOM aims, the one that was most meaningful to Don Berwick was this whole notion of patient-centeredness. We're here today to talk about patient-centeredness because the way we're going to improve our patient satisfaction scores is becoming patient-centered, and those 6 IOM aims and the 10 rules for redesign are focused on achieving this. I have the very last section printed out and posted so that I can read it every day, because this centers my thoughts and helps guide my activities. The last paragraph, call it patient-centeredness, but I suggest this is the core. It is the property of care that welcomes me to assert my humanity and my individuality. If we be healers, then I suggest that is not a route to the point. It is the point. I appreciate you having me here today. This is a wonderful group of people. I'm committed to ensure that we achieve our faith-based mission of faithful, loving care at St. Luke's. It may be a tagline to some. To me, it is evidenced every day in the people that I work with. And I see it as a very tangible value for what we do. Healing does not occur in the absence of that environment. Thank you so much for being here today. I'm glad you let me ramble.